Perfect, thank you. Well, thank you so much for inviting me to speak today, and unfortunately I'm nervous that you might be a bit disappointed. I also wrote a review article back in 2009, and with the exception of a paragraph on checkpoint inhibitors and a paragraph on negative trials, it's still fairly valid today. But I'm going to go over some of the updates from ASCO. I'll go over some of the data on the checkpoint inhibitors. And we're really working to move along this field, even though we haven't been as successful as, say, the melanoma and the prostate cancer doctors have been, not for lack of effort. So here are my disclosures, and I will discuss some off-label use of products during the presentation, but I'll do my best to back them up with data. So I decided to focus on some of the ASCO abstracts from the recent ASCO annual meeting with three main topics. The first is planning concurrent chemotherapy. Most of our patients with head and neck cancer present with locally advanced disease, about 50 to 60%, depending on what series you look at. Most of those patients are going to get concurrent chemoradiation. It's nasty therapy. I think our two objectives there are how to optimize outcomes, but just as importantly, how to improve quality of life, both in the short term and the long term. I'll also be talking about immunotherapy. Immunotherapy has made a difference in how we treat the disease, but it's not perfect. We don't have those 60%, 70% response rates that some other diseases do, so how can we make that better? And finally, I will be presenting some data in the advanced setting on chemotherapy plus bevacizumab. So for head and neck cancer, as I discussed, chemoradiation is the preferred treatment for many locally advanced head and neck cancers. Cisplatin 100 milligrams per meter squared every 3 weeks is the most studied regimen. It is the preferred regimen based on NCCN guidelines. And I apologize, I did have some questions in here, but I got them in a bit late, and I don't think they made it into this slide deck, so I am sorry about that. We know that once you get over a cisplatin dose of 200 milligrams per meter squared, outcomes seem to be better, improved PFS, distant failure-free survival. But we also know that this therapy is tough. Cisplatin 100 milligrams leads to a lot of nausea, a lot of ototoxicity, a lot of neurotoxicity. It's just not easy to take, and there are some suggestions from trials suggesting in the long term that we may see an increased rate of non-cancer related death with high-dose cisplatin given concurrently. So we've tried a lot to figure out what regimens might be better tolerated, but also just as effective. And I know where I trained, lower dose weekly cisplatin was basically the standard treatment, but without great data. We use 40 milligrams per meter squared weekly. So because of the widespread use, but the lack of clinical data, there were two abstracts presented at ASCO that don't perfectly answer the question of is weekly as good as Q3 week, but I think they go a ways towards helping us. The first trial is a comparison of 3 weekly versus weekly cisplatin in locally advanced nasopharyngeal carcinoma. So not a population that I see a lot, but I do think this gives us some data that we can maybe extrapolate towards other groups. This was done mostly in southern China, where nasopharyngeal cancer is far more common than it is in the United States. And here is their clinical trial design. So they took patients with locally advanced nasopharyngeal cancer, 520 patients, and randomized them between the standard treatment, cisplatin at 100 milligrams per meter squared every 3 weeks versus weekly cisplatin, 40 milligrams per meter squared. And their primary endpoint was failure-free survival. So here is their primary endpoint, basically showing that the arms are equivalent. For the once a week, that's OAW versus every 3 weeks. Both arms did very well. There was no significant difference. And overall survival equivalent. So here are the data in graphical form that disease failure happened in about 8% of patients in the weekly arm, 10% in the every 3 week arm, no significant difference between the two, no significant difference in death, distant metastasis, or locoregional relapse. However, we tout the weekly regimen as being better tolerated, but to my surprise, and to the surprise of I think many other clinicians, it was not better tolerated. They actually had more adverse events in the weekly at 40 arm than in the 100 milligrams Q3 weeks. Now, everyone afterwards was kind of scratching their head at this session saying, why is that? Specifically, rates of thrombocytopenia, rates of leukopenia were higher. I still think that this, for most patients, is easier to tolerate than 100 milligrams per meter squared every 3 weeks. because a lot of those side effects are not as easy to pick up. They're not as easy to grade in a clinical trial. You know, all the stuff that makes Q3 week cisplatin so miserable, like the neurotoxicity, tinnitus, the nausea, maybe doesn't reach the grade 3 toxicity, but still really impacts quality of life. So while the hematologic side effects may be more pronounced with 40 weekly, I don't know that that will keep me from using it, because I don't think those hematologic side effects get us in trouble as much as some of the other side effects. Here's another trial. This trial was from India. It was another randomized phase 3 trial comparing weekly versus Q3 week cisplatin in patients with head and neck cancer receiving chemoradiation. This was done mostly in India, and here is the basic trial design, a pretty straightforward trial design. It allowed both patients that were receiving primary definitive chemoradiation and also people that were receiving adjuvant chemoradiation after surgery for their cancers. They were stratified based on the setting, but both were allowed into the trial. They were randomized 1-to-1 between the 100 milligrams per meter squared, and this time the weekly cisplatin was given at 30 milligrams per meter squared. Primary endpoint here was local regional control. And I just want to point out, I hope that slide can be seen okay, but the patient population that was seen here was primarily oral cavity. So about 90% of the patients had oral cavity cancers. I think that reflects some of the differences in tobacco use between the United States and India, where in India, the betel nut chewing is very common, oral cavity cancers are more common, whereas here, tobacco is more often inhaled with use of cigarettes, and we see lower down primaries. Most of these patients were treated Most of these patients were treated by surgery. So here are the curves for local regional failure with the weekly cisplatin in green, the high-dose Q3 week cisplatin in red. And what you can see is that the weekly cisplatin group did significantly worse. They had significantly higher rates of local failure. 39% at 2 years versus 25% in the Q3 week. So that was statistically significantly different, and I think also passes the eyeball test. Now, the question is, it suggests that we didn't get a high enough cumulative dose. We have a lot of research suggesting that 200 milligrams is kind of the magic dose that we try to get to. It suggests that the 30 milligram people didn't get there. Even that doesn't seem to be the case. Even the people with weekly cisplatin that got to 200 milligrams per meter squared still had inferior outcomes. Progression-free and overall survival were actually not significantly different, but follow-up was incomplete. Acute toxicity shown here, there was, not surprisingly, more toxicity in the 3 weekly arm, with 85% of patients with grade 3 toxicity or higher compared to 72, almost a third more patients being hospitalized. Chronic toxicities, however, were similar between the two arms in terms of swallowing issues and things like that seen in the long term. So, in conclusion, for locally advanced nasopharyngeal cancer, outcomes are similar between cisplatin 40 weekly and 100 milligrams every 3 weeks. This trial showed that weekly cisplatin is associated with more hematologic toxicities, and there was actually no decrease in any toxicity seen with the weekly over Q3 weeks. For patients with tobacco-related oral cavity tumors treated with surgery, I think that's the only group we can really get definitive answers on from the Indian trial, just because there weren't enough of other patients in that to really say. But I think we can confidently say that cisplatin 30 milligrams weekly is inferior to 100 milligrams per meter squared and should not be used unless you have a patient that really can't tolerate other treatment. Weekly cisplatin was better tolerated, so if you have that very borderline performance status patient, you can think of it, but it should not be a standard. So cisplatin 100 milligrams every 3 weeks remains the standard of care, and I actually have changed my practice based on this data presented. I was using a lot of 40 milligrams per meter squared weekly, but this data forced me to sit and think, I've been using this, but there's really no data to back up behind my use of this, and now there's some data against it. So I use 100 unless there's a good reason not to. However, the huge caveat here is neither trial addresses the patients that I see in my clinic. I don't see a whole ton of oral cavity tumors. I see mostly oropharyngeal tumors, larynx tumors, a fair number of HPV-related tumors. Neither of those trials address that question. I don't know if a trial will ever address these questions. These aren't the most exciting questions that US groups are interested in asking. So it will remain an open question. I think 40 milligrams is still a valid option for patients that you don't think can tolerate high-dose cisplatin, but if you can use high-dose cisplatin, you probably should. Moving on to immunotherapy. When I said there was only one real advance in the past 10 years or so in head and neck cancer, this is probably it. Immunotherapy, as you know, is being used in a lot of malignancies now, and there's good reason to use it in head and neck cancer. We know that there's high levels of PD-L1 expression in head and neck cancer, and we also know for both HPV positive and HPV negative tumors, there's a fairly high mutation burden. A lot of trials suggest that the more mutations you have, the weirder these tumors look to the immune system, the more likely you can persuade the immune system to recognize them by using checkpoint inhibitors. There are 2 checkpoint inhibitors, both PD-1 inhibitors, approved in platinum-refractory recurrent and metastatic head and neck cancer. That's pembrolizumab and nivolumab, but they're not perfect. Response rates are low, and we don't know how to use them in earlier settings. We all think they have a utility there, but we don't know yet. So this is the data that got nivolumab approved, the Checkmate 141 trial. It was a pretty straightforward trial design. It enrolled patients with head and neck cancer, regardless of PD-L1 expression, who had progressed on or after platinum-based therapy. That platinum-based therapy could be in the locally advanced setting, or it could be in the metastatic setting. Either were allowed. And patients were randomized between investigator's choice chemotherapy, which was a choice of methotrexate or docetaxel or cetuximab, all valid options, versus nivolumab. And I think the data that you see here on the overall survival is quite striking. That there is a significant improvement in overall survival, nivolumab versus the standard therapy. You'll notice that our curves here, we're looking at a 12-month overall survival curve. I got a little bit jealous with the prostate cancer talk looking at 5 years. We don't have that data yet, but nivolumab is clearly better than the standard therapy in terms of overall survival. But one thing I would like to draw your attention to is still the majority of patients die within 1 year. The median overall survival, even with nivolumab, is only 7.5 months. And I think what we've seen in a lot of immunotherapy trials, in pretty much every disease besides melanomas, there's this cliff in progression-free survival at 2 months. The vast majority of patients that get treated with these drugs progress the first time we scan them. So how can we make these drugs more effective for more people? For the people that they work for, they work great and they can work for long periods of time, but that's not most of them. So as mentioned, the big strategy now is combining checkpoint inhibitor plus something else. PD-1 inhibitor plus CTLA-4 inhibitor is a promising strategy. For head and neck cancer, though, I see an elderly group, I see a group with a lot of comorbidities, and that's tough to tolerate. And I don't think that has all that much of a future except for very selected patients in head and neck. So we want to find combinations that are better tolerated and more effective. And this is, I will just highlight one, got an oral presentation at ASCO, and I do think it's probably the most exciting one we have right now. Still very preliminary. There are a lot of trials like this out there, but this is looking at paclitaxel, plus pembrolizumab, and this was the Keynote 037 trial. Ipatacopan is an IDO1 inhibitor. What we know is that tumors can escape from immune surveillance by a variety of mechanisms, and upregulation of IDO1 is one of them. Lots of preclinical data suggesting that inhibiting this pathway can improve responses, and this drug, ipatacopan, is an oral inhibitor of IDO1. So kind of a messy trial design, and they managed to get, I think, something like 6 different abstracts out of this one trial, which I have to applaud them for. But basically there was a dose escalation portion, and then a safety expansion at multiple different doses, and then an expansion at their determined phase 2 dose with 100 milligrams BID of the ipatacopan, pembrolizumab at its standard fixed dosing of 200 milligrams Q3 weeks in 4 cohorts: melanoma, squamous cell carcinoma of the head and neck, non-small cell lung cancer, and renal cell carcinoma. I'll only be focusing on the head and neck cohort today. But here are the response rates. They had 38 evaluable patients in the expansion arm, And for patients with only 1 or 2 prior lines of therapy, they were not allowed prior checkpoint inhibitors, but prior chemotherapy. The response rate was at almost 40%, and the disease control rate was 65%. So this is far better than what we see with the checkpoint inhibitors alone, with the caveat that this is a very small trial, 38 patients. The responses were seen in PD-L1 positive and negative, HPV-related, non-HPV-related, and by the eyeball test, there didn't seem to be any strong differences between those groups, although when you're talking about small subgroups of 38 patients, you can't really draw any statistical conclusions. Grade 3 to 4 adverse events were relatively rare, far rarer than what we see with the CTLA-4 combos, 11%. So I don't think that's higher than what we see with checkpoint inhibitors by themselves. The adverse events that were seen were an amylase lipase increase in 2 patients, which does happen with checkpoint inhibitors. To be honest, I don't know what the clinical significance of that is most times. And to be honest, I don't check amylase lipase in my patients in checkpoint inhibitors unless they're reporting symptoms. I don't know how meaningful the lab values are without symptoms. Fatigue, anorexia, and diarrhea were common. So the other question besides the combination is, can we move this earlier? Most of our patients come in with locally advanced disease, and ideally we'd like to be able to prevent them from getting metastatic disease rather than just waiting till it happens. For HPV negative patients, for all the advances we've made, the rates of failure at 3 years are still about 50%. So even with great radiation therapy, even with concurrent chemotherapy, all the advances in palliative care we still have a lot of people failing. So this trial is a small trial, and caveat, I'm actually involved in it, so it has a spot in my heart. But this is a trial looking at pembrolizumab in combination with chemoradiation. This is a small single-arm trial that they reported on their tolerance data and very early response data. So here's the study design. 1 week prior to the initiation of concurrent chemoradiation, people were given pembrolizumab, and then every 3 weeks throughout concurrent chemoradiation, and then every 3 weeks for a year after chemoradiation. They got standard of care radiation therapy, 2 gray, once daily for 35 fractions for a total of 70 gray, and they got cisplatin 40 milligrams per meter squared weekly. The reason that the weekly therapy was chosen here was to avoid steroid use, which we worry will blunt the effects of checkpoint inhibitors. So basically anyone who is eligible for concurrent chemoradiation is eligible for this trial: oral cavity, oropharynx, hypopharynx, and larynx, stage 3 to 4B. And this abstract is a safety analysis of 27 patients. Enrollment is still ongoing in this trial. So what they found was that we could give effective doses of drug even with pembrolizumab. So weekly cisplatin dose reduces were seen in about 15%, which is about what I see in people that aren't getting the pembrolizumab, that are only getting the cisplatin. Doses were skipped in 26%, which again, I think that's consistent with my clinical practice. 85% of patients got over that magic number of 200 milligrams per meter squared, so that's pretty good. The median cumulative dose was 225. There were not any greater than 5-day delays in radiation therapy, and 100% of patients so far have been able to get to that 70 gray goal. So most patients were able to get all their pembrolizumab. These are the ones that have had time to get all their pembrolizumab. Some of them are continuing on therapy. There were 2 patients that got less than 3 doses that stopped it due to immune-related adverse events during chemoradiation, and another one that stopped it for adverse events after chemoradiation. One was AST increase. One was a very strange peripheral motor neuropathy, which, to be honest, we're not sure if that was truly related to the pembrolizumab versus the cisplatin. One was Lhermitte-like syndrome, where he got the horrible neck pain with looking down that we often see after chemoradiation, but we don't normally see early. He's had it a couple weeks into it. Other discontinuations were due to neck dissection and prolonged hospitalization. But overall, this was well tolerated. The mucositis rates, the dermatitis rates, the dysphagia rates were similar to what we see with chemoradiation alone. And I don't think we saw any surprising toxicities here. So in conclusion, combination immunotherapy may improve response rates over checkpoint inhibitors alone, but it's too early for this to be incorporated into clinical practice. So phase 3 studies looking at paclitaxel with checkpoint inhibition are ongoing. They're actually ongoing in lung cancer, and they're debating whether to move it into head and neck cancer. I think that's a money issue. There's a whole lot more money to be made in lung versus head and neck, but hopefully, hopefully if it looks good in lung, we'll get it in head and neck later on. Pembrolizumab in combination with chemoradiation is tolerable. Too early for conclusions as far as response rates go, although many patients are doing well. There was also a trial presented at ASCO that I won't go into that suggested neoadjuvant before surgery pembrolizumab was well tolerated with some early evidence of response. So hopefully with larger studies we'll be able to move immunotherapy forward. There are RTOG trials looking at nivolumab in combination with chemoradiation. We're still years away from results on those, but there will be bigger trials in the future. So then to move on to a rather depressing topic, which is chemotherapy for recurrent and metastatic disease. As we discussed earlier, most of these patients with head and neck cancer come in with locally advanced disease. We don't normally see distant mets on presentation, about 5%, but many of our patients, their disease does recur after multimodality treatment. Even with the checkpoint inhibitors, they're only approved after platinum-based therapy, so cytotoxic chemotherapy is still our main first-line standard of care. Median overall survival is about 9 months, and of course, we'd all love to improve that. Our current standard of care is based on the EXTREME trial. This took patients who, with recurrent and metastatic head and neck cancer who had not yet received treatment for recurrent and metastatic disease. Most of them had already been treated for locally advanced disease, but it randomized them between platinum and 5-FU with or without cetuximab. Primary endpoint here was overall survival. And of note, until Checkmate 141, this was the only head and neck trial ever to show a difference in overall survival in recurrent metastatic disease. And here are the results. So that top curve is overall survival. You can see the curves do separate. The cetuximab improves overall survival. Bottom curve is progression-free survival. The improvement in overall survival was about 2.5 months, up to 10.1 months, which isn't ideal, but it is improved from the 7.4 with chemotherapy alone. Median PFS, 5.6 versus 3.3 months, and the response rate went up to about 36%. They're relatively similar toxicities, although an increased risk of sepsis with cetuximab, which was rather surprising, and also less surprising, increased risk of skin rash and infusion reactions. So that's not great. That regimen is also tough to give. Cisplatin, 5-FU cetuximab, you have to have people come in on day 1 to get their platinum, to get their 5-FU pump hooked up, to get their first day of cetuximab. 5 days later, they come back to get their pump removed. Most of them, I find, need growth factor support, so then they're coming back in on day 6. On day 8, they're coming for their next dose of cetuximab. On day 15, they're coming for their next dose of cetuximab. Then on day 22, we start all over again. So for patients that have, on average, about 10 months to live, that's a lot of time to ask them to spend in our office. So we'd love to have something better and easier than that. So here was one attempt at that. This is a randomized phase 3 trial of chemotherapy with or without bevacizumab. This was a cooperative group trial that accrued patients here in the United States. So trial design is relatively simple. Recurrent metastatic head and neck squamous cell carcinoma with no prior therapy for recurrent metastatic disease and good performance status. Patients were randomized between platinum doublet and platinum doublet plus bevacizumab. And I would like to draw your attention to the regimens that were allowed to be used, because the platinum 5-FU regimen was allowed to be used, but also what I think is probably better for clinical practice and more convenient for patients is platinum with taxane was also allowed, platinum with docetaxel, which is just a 1-day every 3-week regimen. Primary endpoint here was overall survival. Here were the patients that enrolled. I'd like to draw your attention to the fact that most patients, about 80, almost 90% were treated with the taxane-containing arms rather than the 5-FU containing arms, which I think reflects the fact that this is an easier regimen to give. It's easier on patients, tends to be better tolerated. The breakdown from primary site, there were a wide variety here. Oropharynx was the most common, but all primary sites were well represented. Most patients had a prior history of tobacco use. About 20% were non-smokers. The vast majority of patients had received prior radiotherapy, and most had received prior chemotherapy with their treatment for locally advanced disease. So here are the survival curves. This is overall survival, and while it looks pretty good to the naked eye, it did not meet statistical significance, 12.6 versus 11 months. The chemo-only arm overperformed historical controls here. If you remember, the chemotherapy-only arm in the EXTREME trial was 7.4 months. Now we're seeing 11 months, so we're overall getting better with treatment. Did not meet did not meet statistical significance, so with a p-value of 0.13. If you look at their longer-term outcomes with 2-year survival, higher with bevacizumab, 3-year and 4-year overall survival. And it's unusual to see a trial in this setting talking about 4-year overall survival. Numerically improved, but again, did not meet statistical significance. Here's the progression-free survival. Again, improved, and this actually did meet statistical significance, but hard to know what to do with a statistically significant PFS benefit without an OS benefit, and improved response rates, 36% versus 25%. That 36% is very much what we saw with the cetuximab-containing arm in EXTREME. Adverse events were higher in the bevacizumab arm. I have healthy respect for bevacizumab. I treat both lung and head and neck. I used to use a fair amount of bevacizumab in lung. I don't use a fair amount of bevacizumab anymore as I've had more experience and seen more bad stuff go on. The rate of grade 5, so that's fatal bleeding, there were 5 fatal bleeding events. Fatal bleeding events in head and neck cancers are pretty awful for patients, obviously, but also for their families. If you've ever been present for a fatal bleeding event in head and neck cancer, a carotid blowout, something like that, that's not something you would wish on anyone. So even though it was a relatively small percentage of patients that developed that, I don't think it should be ignored. So the addition of bevacizumab to chemotherapy does significantly improve response rate and PFS. Overall survival was not significantly improved with bevacizumab, and there were more toxicities. So our standard of care remains chemotherapy plus or minus cetuximab. And the EXTREME regimen, though it is FDA approved, I don't use it all the time in my practice because of the convenience issues that we discussed before. And a lot of times I am using a platinum taxane combo frontline. So final points, high-dose cisplatin, 100 milligrams per meter squared, remains the preferred regimen for radiation with locally advanced head and neck cancer, which it has been since the early 90s, which is a little depressing that we're still citing trials from the early 90s for the treatment of head and neck cancer. But here we are. One note about cetuximab. Cetuximab is FDA approved for the treatment. That was based on a head-to-head trial versus radiation alone. And I think there is some good retrospective data suggesting that chemotherapy is probably better, so cetuximab should be reserved for the people that can't tolerate chemo. Immunotherapy is currently only approved as a single agent for platinum refractory disease. I think we'll see progress in this area in the next 2 years. I think it's going to move earlier on to our treatment, maybe before platinum in the recurrent metastatic setting and possibly in combination with radiation, but it's not there yet. Bevacizumab does not improve overall survival, and the EXTREME regimen or platinum-based doublets remain our standard of care for frontline treatment of recurrent metastatic disease. And I think I finished right on time, so thank you. Please email me anytime with questions. I love head and neck cancer. I love to talk about it, so keep in touch. Thank you.